You ready for Monday? Ready for another week? Because that was my favorite ready last week. It seemed hard. So just a couple of things. We do have a guest speaker today. So our guest speaker is Dr. Emily Guzman. And she is an exercise physiologist. She also, like I said, she is specialized in children more than any other faculty here. So she'll probably talk to you about it some unique opportunities for research. She is going to talk to you about physical activity epidemiology. And you guys have been introduced to this idea a little bit. We're rolling up with the obesity slides, and then we started talking about tracing physical activity and inactivity specifically to disease. Okay, that's what she's going to be talking about today. Some terminology is really important to you guys. She teaches the core ExPhys class currently, and will probably continue to teach it at least once per semester, I would imagine, as we do have one new hire coming in this area, as I mentioned to you. On Wednesday, we're going to have Gretchen come in and talk about physical therapy and occupational therapy. Friday, we have a Corbett tour, next is lab experience. And just remember, professional development is due on Friday. Do you guys have questions about that for me? Anything? Nico?
Are both due Friday or just one?
One is due Friday. You have one due Friday. If you have two done, fantastic, turn them in. But one is due Friday, one is due at the end of the semester. All right? So I'm going to turn things over to Emily today. I have to sneak out a little bit early for class. Gretchen's going to come in for me today. We do have some of the intro students from the second class coming in to join us, because Emily has to teach ExPhys at 10 o'clock, so she can't repeat this. She's only going to do it one time. All right, so if you guys have any questions for me, let me know. But thank you so much for joining us, Emily.
Hi, guys. So my training was a little bit different. A lot of times people study one area, but my department at Michigan State, where I did my PhD, focused on children and focused on physical activity epidemiology. So I have these two sort of areas that are related but different. And so the research I'm going to talk to you about later at this particular moment is not really focused on epidemiology. So those aren't going to match up too particularly well. So today we're going to talk about what physical activity epidemiology is, and we're actually going to start out, before we do that, talking about what epidemiology is. And we've got some current events right now that are maybe making epidemiology a little bit more interesting than it usually is. What do you guys have any idea what that current event might be? Ebola. So infectious disease epidemiologists are working very hard right now on Ebola. What might they be doing with that? There are a bunch of different things they could be doing.
Tracking how it spreads.
Tracking how it spreads. They would also like to know how it started and where it started, which helps us figure out how it spreads. So you can go online and you can read some articles speculating about who the first patient was and how that patient, who they think was a toddler, got it. And then how it spread from that toddler to other members of his family, and how his grandmother got it and went to a city for treatment and wound up spreading it to people in the city from her small rural village. So you can read about those things. That's what infectious disease epidemiologists are doing right now. How many of you have seen World War Z? What happened in World War Z? Speak up, please.
There was an outbreak of a virus that,
What kind of virus was it?
zombie virus.
It made people into zombies. So there was an outbreak, and then what was Brad Pitt's job? He had to find a cure, and in order to find a cure, what was the first thing they had to figure out?
Where it was coming from.
Where it was coming from and how it spread. So it was spreading by the people who had the virus, biting the people who didn't have the virus. What did they figure out? If you injected yourself with a terminal illness, that the zombies would pass you by because they would know that you were dying, so you wouldn't be a good host. How did they figure that out?
He saw zombies driven by cancer patients.
He saw zombies just completely passing by cancer patients and the very, very old, and just completely passing them over because they wouldn't be good hosts for the disease that the zombies were trying to spread. So obviously that's kind of a ridiculous example, but the same sort of principles applied. They figured out what it was, where it came from, how it was spreading, and then how to stop it. So that works for infectious disease epidemiology, but it also works for physical activity epidemiology. The situation is just a little bit different. So we're gonna talk about how that works when it's not an infectious disease that's spread by biting someone. And then we're gonna have an in-class activity to sort of try to use some of those principles a little bit. So epidemiology is simply the study of a disease in the population. So it can be infectious disease where you're trying to figure out what Ebola is and how it spreads. Or it could be cardiovascular disease, and you're trying to figure out what puts people at increased risk for cardiovascular disease and how that can be treated and prevented in our population. So one is infectious, one is not. But they're both still diseases that are occurring and are a big public health concern. So epidemiology can be further broken down into descriptive epidemiology and analytic epidemiology. If you guys had to guess, how would you think that descriptive and analytic are different? Just based on those terms. Yes, both of them are using a large mountain of data, but what would they be analyzing it for? You looked at obesity maps with Dr. Perkins, right? Do you think the process of creating those maps was descriptive or analytic? It's actually descriptive. So descriptive there is looking at what the distribution of the disease is in the population. So for that actual example, figuring out the distribution of obesity by state or by county is descriptive. But then what might an analytic epidemiologist do with that information? So they could take that descriptive information and do something with it, yes.
Try to figure out how to lower those numbers.
They could try to figure out how to lower those numbers. So what could we do to treat it? Or what causes Colorado to be different than Louisiana? So the analytical person is trying to figure out causes and treatments. The descriptive person is looking at differences in distribution by state, by county, by person. So you're looking at establishing the rates of a disease or a health-related event, so comparing Ebola rates in different countries. Have you all seen the maps of Western Africa showing the rate of the disease in the different countries? You can go out and find those. I should have downloaded some of those for you for today. So you can go out and look at those and see how Ebola is being distributed differently in different countries and different parts of different countries. So it helps us understand how common a disease is, and it helps us start to identify differences in different aspects of the population. So you might see that some people are different. For instance, obesity rates are a lot higher among African Americans than white Americans. So you can see that those differences, and then an analytical epidemiologist can start trying to figure out why those population subgroups might differ. By place would be looking at states, and then by time, did you see obesity maps over time or just as one snapshot in time? You saw some over time? So the CDC has this PowerPoint presentation animated that starts in 1985 and goes all the way up to now and shows you how the distribution of obesity has changed, of course, across your lifetime, more than your lifetime, right? So that's descriptive as well. And then analytical, like I said, is trying to figure out why all of this is happening. So they might be trying to figure out causes of different diseases. They might also be trying to figure out treatments of different diseases. So if we notice that adult African Americans tend to have much higher obesity rates than adult white Americans, what might be different about those two population groups that might cause those different obesity rates? So an exposure would be the thing that's different. Maybe there's some sort of cultural difference, maybe there's a socioeconomic status difference, maybe there's a genetic difference. So the exposure would be that thing that's different between the groups, and then the outcome in that particular example would be obesity. What do you think would be another word that you learned in other science classes for exposure or statistics classes?
Independent variable.
Yep, the exposure is the independent variable. You could also call it a determinant, or you could call it a risk factor. So you've learned about risk factors for cardiovascular disease. You could call an exposure a risk factor. But sometimes an exposure is a good thing. Physical activity could be an exposure. So it doesn't just have to be a risk factor, it can be a good thing too. And then the outcome is the dependent variable. So if it's a disease that you're interested in, the outcome would be the disease. So determinants can come from a lot of different areas. They could be biological, like a genetic difference. They could be social or cultural differences, so maybe difference in traditional foods. And then behavioral factors includes things like physical activity, stress management. So from an obesity standpoint, we could sit here and we could list out what those different factors might be. So we are making some assumptions when we collect all of this information and try to draw a link between an exposure and an outcome. One of those is that we're assuming human disease isn't occurring at random, it is actually caused by something. And we're trying to figure out what that something or multiple somethings might be. And we're assuming that human disease has causal factors and preventative factors that we can identify. So if we're looking at obesity, we're assuming that it's not, like I said, not random. We can figure out what is causing it, and we can figure out what to do about those causes to prevent the obesity epidemic from continuing to get worse. And so the goal is to take this information, figure out what is causing diseases, and use that information to decrease morbidity, which is basically the occurrence of the disease affecting your quality of life, and mortality, or death from that disease. So I've used obesity as an example pretty much all the time here. What other kind of activity or inactivity related diseases could a physical activity epidemiologist study? What other sorts of diseases are related to physical activity?
Cardiovascular disease.
Cardiovascular disease, yep.
Diabetes.
Diabetes, type 2. What else?
Osteoporosis.
Osteoporosis, that's a great one. What else?
Some cancers.
Some cancers. So those are all pretty easily definable physical ailments. Is there anything that's not as easy to define? Depression. Anything else related to depression?
Anxiety.
Can you think of anything else? Can you think of anything that physical activity might cause that is not good? Injuries. So a physical activity epidemiologist might also study injury prevention in youth sport. So I always like to bring up one where it's not a good thing. So physical activity epidemiology is taking those principles of epidemiology and applying them specifically to physical activity. So we look at the association of physical activity as a health-related behavior with disease like cardiovascular disease or cancer, and other health outcomes like injuries in youth sports. We can also look at distribution and determinants of physical activity behaviors. So we could compare, instead of obesity rates state by state, we could compare physical activity levels state by state and figure out why some people in some states are more active than people in other states. And we can look at how physical activity is related to other behaviors. So what other types of behaviors have you guys noticed from yourselves are related to physical activity? What do you do differently when you're exercising a lot and when you're not exercising a lot? You sleep better? Eat better or worse if you're not exercising a lot, maybe?
Get more done.
get more done, you're a little more productive, not quite as sleepy, because you're sleeping better and because exercise is energizing, and you're eating better. So those behaviors are related to each other. What about smoking? Smoking related to physical activity? Do you see a lot of people light up after they're done running a marathon? Okay, so you all laugh, but do you?
No.
No. So those behaviors are related as well. And then we can take all of that information that we gather and apply it to preventing disease and controlling disease in the population and promoting health and healthy behaviors. And of course, preventing disease and promoting health are related to each other. So, why is physical activity epidemiology important? Or another question, why did I turn those 4 diseases red?
Because if you don't, like, do physical activities, then you will have a higher chance of developing diseases.
Physical activity is related to the development of all 4 of those diseases. So the red ones, if you can't see, are heart disease. What is malignant neoplasm? What did you say? You whispered something, I didn't
Was
hear.
it very impressive?
Very
to-
impressive.
to the-
What's malignant neoplasm? Cancer. Cerebrovascular disease, what's another word for that? It is brain. It's not cancer. Vascular, what's that? Stroke. So it's injury to the blood vessels in your brain, so that's stroke. And then diabetes mellitus, this is really specifically type 2, is related to physical activity. So this is the top 10 causes of death in the United States in 2005. Those 4 diseases account for almost 60% of deaths that year. So almost 60% of the things that people died from in 2005 could be possibly outright prevented by being physically active. And some of these others also might be related to physical activity. Yes, sir.
Is there a certain age range between these, or is this?
This is adults. If you look at children and college-age students, accidents bump up higher and some other things like that, so this is adults.
What if people are just too old to exercise and stay active?
Is there such thing as being too old to exercise?
I mean, not.
Why did you say that? You said that for a reason, right? Why did
Yes.
you say that?
Because like some people have like their bones are too frail to get up and do extreme like jogging.
So if we take someone who is 85 years old, who has been inactive for the previous 85 years, they may not be in a situation where it's incredibly smart to start being physically active at the age of 85. So what does that mean to you? I know what it means to me. What does it mean to you? We need to be promoting physical activity throughout the lifespan, so we don't have people who are 85 just starting to try to exercise and prevent disease then when it might be too late. So it's much better to start this earlier. And at 85, is it going to make a difference on these things? Maybe not. What other things are not read on there that could maybe be influenced by physical activity? Unintentional injuries might be. If you're stronger and have better balance and a little better coordination and agility, you might be less likely to fall. Can the flu and pneumonia be influenced by physical activity? Does exercise do anything for your immune system? I'm getting nods. Exercise is interesting with your immune system. To a certain point, it can boost your immune system, and if you do too much and you don't recover enough, it can damage your immune response. It can suppress your immune system. So it could actually fall on either side here. And then there's some discussion that maybe we should move the healthy BMI range up higher for seniors, because if they get influenza or pneumonia, and they're already on the side of underweight, and then they can't eat, and they lose weight while they're very sick, that increases their risk of mortality. So physical activity might be related to some of these other things, but they might be a little bit more complicated than they are for those 4 that I turned red. But so at least 60% of deaths among adults are related to physical activity. So just a couple other terms that I want to talk about. Physical activity is bodily movement produced by skeletal muscle that raises your energy expenditure substantially over rest. So if you're sitting and fidgeting in your chair, that's not really physical activity. But pacing back and forth in the room like I am would be enough of an increase in energy expenditure to be physical activity. It's not moderate intensity, it's not going to do anything for my fitness, but it is going to do something for my total daily energy expenditure. How is exercise different from physical activity?
Exercise is like you do it on purpose to build your fitness.
You do it on purpose for a reason, for a goal, which is usually building your fitness. Why else might you exercise besides getting more fit?
Improve your health.
To improve your health. I know there are other reasons. Why else?
You're an athlete,
Yep, so if you're an athlete, to improve your performance. Anybody exercise to look better? Yeah, nobody ever likes to admit that one, like that reason doesn't count. That reason does count. People exercise to look better too. Officially, it's physical activity that's planned, structured, and repetitive, and results in improvement or maintenance of one or more of the components of fitness. So when we're talking about physical activity, epidemiology, and disease prevention, we're almost always talking about aerobic activity. But we do sometimes talk about resistance training. We've started talking about it more recently because we're starting to get better evidence on how resistance training is associated with health. What's one of the diseases that we listed earlier as being associated with physical activity that would be strongly influenced by resistance training? Heart disease is still controversial. Osteoporosis. Resistance training is strongly associated with bone mineral density. So some of the rates that we look at mortality rate, which is the rate of people who are dying from that specific disease in a given period of time. So for Ebola, it's per week. For cardiovascular disease, it might be per year. And then the morbidity rate is a way to describe the number of people who have the disease. So we have the prevalence rate and the incidence rate. Those obesity maps that you guys looked at are the prevalence rate. They're showing you the percentage of people in the population that are obese. For Ebola, people are talking a lot about incidence rate, and that's the number of new cases in a specific period of time. So again, it's per day or per week when we're talking about Ebola and an infectious disease outbreak. For obesity, we might talk about new people who are newly obese in the past year. So it tells you how fast it's increasing. Prevalence only tells you what it is right this second. Or incidence rate could tell you if it's slowing down, which would be nice. So prevalence doesn't have a time component and incidence does. So these are the obesity maps. I'm not sure if they're the same years that you saw before, but these are the same maps you saw before. So here we have the prevalence of obesity in American adults in 1990, 2000, and 2010. So in the 1990 map, the white states are states that didn't have data. They're not the lowest rates. They just don't have data for those states. The lowest rate is the light blue. So in 1990, the lowest rate were some states, primarily in the West, that had less than 10% of obese adults. By the time we get to 2000, that light blue is gone. We have only the next step up in blue, which is 10 to 14%, and that's only one state. Which state is that? Colorado. And then we've added this darker blue, which is 15 to 19%, and the yellow, which is 20 to 24%. 10 years later, all of the blue is gone, much of the yellow is gone, and we've added orange, which is 25 to 29%, and the dark red, which is greater than 30%. So that's 2010. They're still collecting this data. They collect it every year. I'm sad to say they changed the colors on the map, and I really wish they hadn't done that, because now it's not as good of a slideshow as it was before. This is data from 2013. And this is split by ethnicity. So we have non-Hispanic white adults, non-Hispanic black adults, and Hispanic adults. So Wyoming, Montana, and Idaho are white here because the non-Hispanic black population of those states is so small, they don't have enough data to report. But if you look here, once again, the lighter colors are lower obesity rates. So the lightest color is the green with the little dots. So once again, who wins that one? Colorado wins that one again. So among non-Hispanic white adults in Colorado, 15 to 20% are obese, which is still more than that 10% that was shown back in the 90s. What about non-Hispanic black adults and Hispanic adults? What do you guys see? I know Dr. Porter talked some about health disparities. Do you see health disparities on that slide right now? What do you see?
Percentages are higher all over for both non-Hispanic, Black, and Hispanic.
So overall, the obesity rate is higher. The light green with the dots is gone entirely from these other two maps. And most of the next green up, which is 20 to 25%, is gone too. What's added? Dark red. And what's the percentage of the dark red? At or above 35%. That wasn't even on the graph in 2010. Who is by far the worst? Non-Hispanic black, especially in the South and on, well, the eastern half of the country, basically. So, this is kind of a depressing slide to finish up with, but it is the slide that I'm finishing up with. I have an activity for you guys. I want you to work in pairs. I'm going to hand out. So there's something for you to read here. This is a report from the World Health Organization on promoting health through physical activity. There will be extras of these, just hand me whatever is left over. So what I want you guys to do is read this approximately page of information from the World Health Organization. And then there's a graph on the back side that shows causes of death, the percent of deaths that can be attributable to these different causes. One of those causes is physical inactivity, or not meeting physical activity guidelines. So I'm going to have you read this report and then talk with your partner about which of those causes of death can be related to physical inactivity. So take a few minutes to read this and then get together with your partner. Once you've read everything, go ahead and find a partner and start talking about the relationships or lack of relationships between physical activity and those other causes of death. And I want you guys to take some notes so that we can talk about them as a class before we're done for the day. Nobody ever wants to be the first group to start talking, just go ahead and don't be shy.